Laken's a second-year medical student at OHSU. We are seducing him into the world of NBIA. So the prime of Miss Jean Brodie, give me a boy at an impressionable age and he is ours for life. So he's been rotating in the clinic with Dr. Wilson, who you met yesterday. And he's been joining us in our meetings, and we had an opportunity to be involved in this project looking at something that comes up pretty frequently in PKAN and often is a course of crisis, where we get calls from clinicians around the world, actually, about usually children with PKAN who have fractures. And so we are looking at this systematically. And again, the natural history study has helped us to, and the information that we collect over years has helped us to sort this out. So Laken's going to be talking about that. Thanks.
All right, yeah, thank you. Hello everyone. My name's Laken. Like Penny said, I'm a second-year medical student at OHSU, and I'll be talking about fractures in PKAN. Oh. Hello? Is that better? Okay. Yeah, so I'll be talking about fractures in PKAN. First, I just want to say, yes, this is my first time attending one of these family conferences, and I think you have quite an amazing group here, so I feel really fortunate to have the chance to talk with you all today. Also, I want to give a special thanks to Dr. Scott Yang. He's a member of the orthopedic surgery department at OHSU, and he also helped oversee this project. So first, I just wanted to talk about some brief background on why we wanted to look into fractures in PKAN. We know that in people with PKAN, there's a couple things that potentially put them at risk for injuries to their bones. First, we think of something called osteopenia, which is really just a fancy word for a weakening or thinning of the bones. We see this not just in PKAN, but anyone that's just not moving around, walking, or bearing weight on their legs. Their bones can just get weaker over time, and that can put them at risk for injuries. In PKAN, we also see, they get this dystonia that can progress over time, and just that tension or twisting on the bones is something else that could potentially put them at risk for injury. So because they just have a couple of things, that put them at increased risk for injury to their bones, we wanted to look into this. We wanted to know, in somebody with PKAN, if they get an injury to their bone and they need surgery to fix it, what is it that, we can expect to happen, and what do we need to know so that we can help these bones heal as best as possible? So the first thing we did was we wanted to look at what was going on at the time of the initial injury. We were able to look at 5 people with PKAN. 4 had classic PKAN, 1 had atypical PKAN. All of them weren't able to walk or move around at the time of injury. All of them had that osteopenia, or that weakening of the bones, at the time of injury. Most of them, the type of injury they had was a fracture to their thigh bone or the long bone in their leg. There was also one person that had a hip dislocation, but the majority of them were fractures. In terms of the dystonia that was occurring at the time of injury, all of them, as expected, had some degree of dystonia. However, 3 of them had this dystonia that was reported as being worsened compared to their baseline when the injury occurred. And also, there was only one example, one person, where they were able to identify a direct cause of the injury, or some kind of trauma that was noticed that caused the fracture. And the rest, they didn't know what the exact cause was. They just presented and they had this injury, and no one was really sure what caused it. So the next thing we wanted to look at was the outcomes, or what happened after they had to get surgery. There's really 2 important things we wanted to look at. We wanted to see what their dystonia was like after the surgery, and then how long they needed to be in the hospital after the surgery. So in 4 out of 5 of the people, we saw that their dystonia worsened after the surgery. And then in terms of hospitalization, 4 out of 5 had to stay in the hospital for a longer period of time. The average was around 2 to 3 months after surgery. And importantly, those 4 that had to stay in the hospital for a longer period of time, it was the same 4 that had this worsened dystonia. So that seemed to complicate things after the surgery. In the person that didn't have any worsened dystonia, they actually only needed to be in the hospital for a few days after surgery, and they were able to go home. Now, in terms of the surgery itself, we saw that in 3 of the people, the first attempt at surgery didn't work and they needed another surgery to fix it. 2 out of those 3, the reason the surgery didn't work, it was said to be because they had a pretty severe episode of dystonia after the surgery. And I think for this, it's better to just show you pictures of what happened so everyone can see what happened and what was done to try and fix the problem. And I kind of want to wander down here to point at things, so I don't know if that's allowed, but I'm going to do it. Okay. So in this first picture, this is all examples from one of the kids that had a fracture. This first picture is just showing that initial injury. So they had a fracture to their thigh bone, and they needed surgery to fix it. This next picture isn't the best. There's a better picture on the next slide that'll show things a little better. But this is showing what the surgeon did to try and fix the problem. So what this is, it's just a metal rod that goes into the bone, and it just kind of holds the bone in place so the fracture can heal properly. I don't know if you can see it, but there's these 2 little holes right here. And that's a spot where a surgeon can put screws in, and that just holds that rod in place to kind of keep everything together. In this case, you can see there's no screws there. That's because the surgeon was worried because this patient had that osteopenia, so their bones were weak. They were having worsened dystonia up to the surgery. So they were worried if they put screws in, they were just going to hurt the bone more. So they chose not to do it. However, what ended up happening was they had a pretty severe episode of dystonia after the surgery. So that actually caused this metal rod to move down into the knee. So unfortunately, the first attempt didn't work, so they had to do another surgery to try and fix that problem. So this is showing what the surgeon did to fix that first surgery. So they got a second surgery. And I don't know if you can see it better here now, but this is showing these screws. So what they did was they went in and they immediately moved that rod back up to where it's supposed to be. And now they put in screws down here kind of right above the knee, and then they put screws in up closer to the thigh. And I don't know if you can appreciate it in this picture, but this is showing an x-ray from a couple months later after that second surgery. And what it's showing is this is the where the fracture was. It's showing that the bone is healing. So after that second surgery, the fracture stayed in place, the rod stayed in place, and the bone was able to heal properly, and they didn't need another surgery. This is just another example from another one of the kids that had a similar injury. They also had a fracture to their thigh bone, and they needed surgery to fix it. That top right picture is showing that first attempt. They used a different type of surgery. This is just like a metal plate that kind of rests on the outside of the bone. And then this picture right here, this is showing, again, this person also unfortunately had a pretty severe episode of dystonia after surgery. So this metal plate just wasn't able to hold the bone in place, so they needed another surgery to try and solve that problem. And I don't know if you can tell, but this is that second surgery, and it looks pretty similar to the one from the previous kid. So they actually used that same type of surgery. They took that metal plate off, and they put a metal rod in, and then they put screws in at 2 different places. And just like the previous kid, this held the bone together and held it in place, and the bone was able to heal properly, and they also didn't need another surgery. And I don't have any pictures of this, but there was another person, the person with atypical PKAN, who had a similar injury as well. And the first surgery they got was that metal rod with the 2 screws, and they didn't need a second surgery. It held everything in place on the first try. Yes. So finally, so what did we learn? What were kind of some key takeaways from this study? The first thing, we saw that, like I mentioned, in most of these people, except for one, we weren't able to see a cause of what caused the injury. So going forward, it's really important to be on the lookout for new injuries as their dystonia seems to progress. Most of these people presented at a time when they reported their dystonia was worse, but yet there was no direct cause noted. So as the dystonia progresses, they may have an injury that's not obvious and could go unnoticed. So we really just want to be on the lookout, both as families and healthcare providers, for any new injuries. Also, like I mentioned in the beginning, bone health is really important. All of these people had osteopenia, so their bones were kind of weak, which probably put them at risk for these injuries that they got. So we think going forward, it's just going to be really important for as much as possible, as long as possible, to try and bear weight to keep the bone strong, as well as medications or supplements that also increase bone strength to just try and lower that risk for injury. In terms of the surgery itself, we actually now have a pretty good idea of what surgeries seem to work best. Like I said, there was one person who got that metal rod with the screws on their first try, and they didn't need a second surgery. And you know, we saw that dystonia got worse after surgery. So we don't want to have to have people with PKAN get multiple surgeries if we can avoid it. So I think it's a really good thing that we now have some evidence of what seemed to work best. And I think, like Penny mentioned, we're working on a more detailed write-up. So that way we'll have this information will be out there so that the next time somebody with PKAN needs surgery, a surgeon will have access to this information, will have a better idea of what will work best to help them. And finally, we really wanted to emphasize the importance of multidisciplinary teamwork, which is really just a fancy way of saying everyone in the hospital needs to be working together to help people with PKAN. Like I said, we saw there was this risk for severe dystonia after surgery, so we can't just have surgeons operating on the bones and only focusing on the bones. There's other factors at play here. We saw that we needed a good neurologist managing their medications very closely before and after surgery to try and mitigate that dystonia. We saw that it was important for the anesthesia teams to keep a really close eye on their sedation. There was a couple instances where they had to be really slowly taken off sedation or even put back on sedation to try and manage that dystonia after surgery. So really, it's just crucial that everyone, regardless of their discipline, is working together so that we can try and keep people with PKAN safe and healthy and reduce those risks for complications. Thank you. Yeah. 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 Yeah, so the question was, besides weight bearing, what are some other things that can be done to reduce the risk for osteopenia? What? I know a couple things, but you can add things as well. Yeah, I'm a student. I'm used to asking questions, not being asked questions. Yeah. Yeah, so like we talked about the weight bearing as a team, but we know that that's not always reasonable. We think that's maybe more of an earlier intervention to try and keep them weight bearing as long as possible, but we know it'll get to a point where that might not be one of the solutions. So I think one of the big things is supplements, you know, like calcium, vitamin D, things to strengthen the bones. There's also some medications. I know there's like bisphosphonates are a type of medication that can be used to strengthen bones. Even people that don't have PKAN will take that for osteopenia. I don't know if there's any other options that you would think of. Bisphosphonates. Yeah.
So one of the things that, I mean, it really illustrates how, you know, any team is only ever going to see one patient probably with PKAN who has this type of a course. And so, well, unless you're in Michigan, of course. But it sort of illustrates the power of a natural history study and collecting data over many years, because the only way we could collect 5, 6, 7 cases and you know, others that we've seen in consult is by kind of being involved in the care of PKAN patients over years and collecting this information in a systematic way and being able to put something like this together. And it isn't going to inform care going forward. And so one of the things that we are trying to, you all are aware of the best practices guideline, and that's something that we hope to sort of revise and update, and it will include, I hope, a more complete guidance on bone health. So when we talk about weight bearing, you know, the natural history of PKAN, particularly classic PKAN, is that they lose weight bearing ability, but there are standards even after somebody can't walk independently, and that probably has some benefit for increasing bone health. Just weight bearing is perhaps one of the most important things. But bisphosphonates, you know, it's not a knee-jerk, you just go put somebody on bisphosphonates. It's a big decision to do that because there are some consequences and challenges in doing that. And so we want to be very sure that that is the right thing to do. There's a lot of information from the cerebral palsy literature, and Dr. Wilson actually has been incredibly helpful in pointing us to some of those best practice guidelines in CP that can help us develop something in PKAN. So we hope to be able to put together some more directed guidance that is, you know, informed by this project and by other populations. And we don't want to send everybody away with sort of totally freaked out that their child or adult is likely to get a fracture. These are rare, but when they happen, we now have some pretty good data to provide guidance for how to manage it and to avoid some of these complications. You all know that pain increases dystonia, and so this management after surgery is so challenging. And you know, when we can talk to people at OHSU, we can then, now this will be in the literature. I mean, it's being written up now. We hope to put it into press very shortly. It's something that we can point people to. Surgeons can find, even if they don't find us, they can find this. They can see something that says, if you've got a child with PKAN in your, and I say child because it usually is a child, in your ICU, here's what has worked and here's what has not worked well. And we never did have that before. And so it's a beautiful example of how data can improve care. And so I really appreciate Laken and Dr. Yang for sort of taking the lead on this project, and Dr. Wilson and our team for sort of helping to put it together. I think that it'll help. So watch this space and we'll get some more guidance. Yeah, quick question, and then we'll move on. Yeah, we did. Would you like to address it? Endocrinology? Do you want me to jump in?
I know the paper touches on it a little bit, but I don't know if you have more to say on that.
We actually did, for the patient who was at OHSU, we involved endocrinology pretty carefully, and I think as we develop best practices guidelines, endocrinology will be involved, because they're often the ones who make the decisions about using bisphosphonates, because as I said, they're not simple medications to use. There are. Exactly. So you know, lots of people besides folks like this, you know, there's a whole world of literature about treating osteopenia and osteoporosis in older people usually, or people who have risk for thinning of their bones, usually because of aging. But the very, very expensive alternatives to bisphosphonate, you know, it's a hard sell to insurance companies to get them to pay for it, and so we've got to have data. And I think endocrinology is going to be playing a key role in helping us to develop those guidelines. So thank you for the question. Okay, I think I'm up next. Thank you, Laken. Nice job. Didn't he do a great job? Well done.